Depends on what you're into. Yeah, right? All right, so the barium enema. Barium enema is a study of the large intestine. We also call it the lower GI. So most common way of studying the lower GI is with the use of barium, but again, there's contraindications as with the upper GI and also small bowel in being careful in the use of barium. So the barium enema purpose again is the radiographic examination of the large intestine. It's generally done as a double contrast study. So the primary media that we use here is barium and also negative contrast, which is air. Double contrast, just like in the upper GI, is very good in looking at the internal mucosa of the anatomy. So let's just do a quick discussion on the anatomy. So this should all be reviewed. When referring to the large intestine, there are some nuances because you hear large intestine, you hear colon. And they refer to some of the same anatomy, but the terminology, there's a slight difference. So when we're talking about the colon, it refers to the ascending, transverse, descending, and then the sigmoid. Now, if we're talking about the large intestine, we are including the cecum and then the rectum. Okay, the cecum and the rectum are not included as part of the colon. So when we include those, it's part of the large intestine category. So that's the nuance. All right. So we have So over here we have the cecum. This is the area where the small intestine interacts with the large bowel. Off the cecum you have the appendage or the appendix. And then you have the first vein, which is the right colic flexure or the hepatic flexure. And you will notice that this flexure compared to the left colic or the splank flexure is a little bit lower. And it's lower because of what? Because of the liver. So the liver pushes it down. Okay, so the right side is going to be lower. And then the descending, the sigmoid colon because it has an S shape, and then you have the rectum, and then the terminal opening, the anal canal. Right? Any questions about this? All right, the rectum and the anal canal is part of the large bowel, not the colon, as it says up there. It generally begins at the level of S3, and it hugs the curvature of the sacrum. The rectum is approximately 4.5 inches long. The anal canal is approximately 1 to 1.5 inches long. And keep in mind, again, when we are looking at the lateral view of the rectum, it has this funny shape to it, which is important to understand the anatomy of that when inserting the enema tip. So there is a proper way in which you insert the enema tip without causing damage to the mucosal lining. So we'll talk about that here in just a little bit. So here we have a radiograph of the large intestine. What's unusual about this is that this is single contrast. Rarely do we do single contrast studies, but when we do a single contrast study, it's generally not barium. We would use iodine instead. So, how many of you guys have seen a barium enema? Okay, just a few of you guys. Now, each time when they perform the enema study, they also instill air in the colon. Okay.
After every shot.
Okay. How about someone raise their hand back there? Also with air? Do you remember?
I'm not sure.
You don't remember? Okay, just like you were just in shock, right?
I don't remember anything. Still in shock.
But this is a single contrast study. So again, keep in mind that barium is a lot more dense than iodine. So when dealing with barium type of procedures, you're usually using high kV because it's more dense. You need higher kV to penetrate the anatomy. So generally when we're doing these type of procedures, we're kind of in the realm around anywhere between 110 to 125 kV. And then if you're doing gastrogafrin or iodine, anywhere between like 85 and 95, because again, it's less dense, 85 to 95 kV. All right, so barium is introduced through the rectum, and it's a retrograde flow. So we're going backwards. So we fill up the bowel, starting with the rectum, sigmoid, ascending, and then transfers, and then down to the, descending over here, and then the ascending over here. And this is actually a very good radiograph of this because you can see the appendix. You shouldn't see the small bowel because there's a valve there, that ileocecal valve, okay? So it prevents any flow of the contrast media into the small bowel. The difference between the large intestine and small intestine includes the internal diameter. The large intestine is greater in diameter than that of the small intestine. Hostras are the little pouches that are formed by the tinea colae, which is fibrous tissue. They have 3 bands of fibrous tissue that goes throughout the length of the colon, and it acts like the cinch on a bag, okay, like a duffel bag, the cinch, and so it allows it to expand and contract, but it also creates those little pouches, which are important in the propulsion of the waste material from one end of the colon to the other. And then you have also the general location. Small bowel is centralized, whereas the large bowel is in the periphery. Okay, any questions? All right, so you guys remember that app I've been trying to tell you guys to get? Okay. This is really good to use. So if you guys don't have it, what I've done is I used the app, took some screenshots, and I put it up here so you can see how the dimension, not only the dimensions, but the orientation of the colon. So again, here's your ascending. This area over here is where you find the papilla that communicates with the biliary ducts. You guys remember the gallbladder and the bile? The bile is delivered into this area, okay, to aid in digestion. All right, so we have our ascending, transverse, descending, and then the sigmoid. And if you look at it at the lateral view, take note that you will see that the ascending and descending are posterior. So the ascending and descending are posterior, okay? They're towards the back. And then the transverse colon, this right here, is anterior. And then the sigmoid goes from anterior to posterior. So this entire area right here is the sigmoid colon. So here's the sigmoid. The sigmoid is this portion right here. So it goes from anterior to posterior, and then the rectum and the anal canal are posterior. So knowing the orientation will help you understand what position the patient is in when we are studying it radiographically. So, you know, where the barium and the air should be seen in their different positions, just like in the stomach. Okay, any questions about this slide? All right, so if we go over here, air and barium distribution in the large intestine. If the patient is lying or laying on their back, okay, so the weight of the barium is going to move posteriorly. If you recall back in this image here, if they're laying on their back, where should we see the barium?
Ascending, descending?
Ascending and descending, right? So when they're laying on their back supine, you'll see the contrast, ascending and descending. Okay. You should also see some of it filling up here in the sigmoid area, because recall in this image back here, the sigmoid goes from anterior to posterior. So you may see some filling in this area too. You may. Okay. And then anteriorly, when they're in a prone position, so now they're in a prone position face down, the weight of the barium now is going to go towards the most anterior part of the colon, and that would be the transverse. And so here you'll see part of the transverse filling up, as well as the distal part of the colon, the sigmoid area, where it goes from anterior to posterior. So you're going to see this area fill up too in contrast. And the black area is just air. Air goes in the opposite direction. Any questions? All right, so here, this here is a double contrast study. So you can see contrast filling parts of the bowel, and then you also see air filling up parts of the bowel. But the double contrast study is, again, it highlights the internal mucosal lining of the bowel, and you get a very, very good depiction of the lining. And it says here it's AP, so if it's AP, they're laying on their back, so that would mean the contrast should be where?
Ascending,
It should be
descending.
the ascending and descending, which they are. Okay? And we also said that also in AP, parts of the contrast should also fall in the sigmoid rectal area because it goes from anterior to posterior. So you're seeing part of the rectal sigmoid area also filling up with contrast. Okay. So we have an individual here who may be astenic or hypostenic. Because you'll see, well, first of all, here's the ascending, okay? And notice that the right flexure is a lot lower than the left flexure. You guys agree to that, right? Instead of the transverse colon going horizontally, you see kind of taking a dip a little bit. And this is indicative of an individual who is astenic or hypostenic. Okay, it has that little droop. Okay. And then we looked at that last week, right? Here's a cecum of the ascending colon. Here is the ileum, and then you got the ileocecal valve. Remember, it's really, really small. So when we're doing a barium enema, hopefully there's nothing wrong with that ileocecal valve and the small intestine doesn't fill up. I had a procedure. This is a long time ago. So I'm talking about over 20 years ago. I had a procedure where we did it was a gastrographin enema. We didn't use barium because there were indications that this patient may have had a bowel obstruction. So we used gastrographin. And so we filled up the bowel with the gastrographin. And you guys want to hear this? He started tasting the gastrographin. There was a defect in his valve. So the contrast went to the small valve, up the stomach, in the esophagus, and was tasting the gastrographin and all the whatever was in the bowels.
Nice.
Yeah. And the doctor's like, this has never ever happened before. Never happened. Because usually if there's a defect like that, it kind of just stays in the small bowel area and no further, but this thing shot up all the way up.
So it means that he also had reflux,
He had
right?
a whole bunch of problems.
Because it wouldn't
A
have
lot of
come up.
problems, yes. Yes.
Did they worry about all the bacteria that had?
Oh, sure, yeah. 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 Of course. All right. Okay, so here we have a lateral projection of the rectum. So this is one of the views that you will be taking, is a lateral view of the rectum. And so you can see the hips and the femur, right? Bilateral femur. And so here is the rectum right here. Let's do it right here. Right here. Okay. Rectal sigmoid, and then this is the larger rectum. This is the rectal sigmoid area. And then notice that you see all this filled up with air, and then you got that little black thing over there. What's that black thing?
Isn't air supposed
Poo
to
is
be
solid,
black?
right?
So why you're saying the white part is
No,
air?
yeah, white is
No.
barium. So what's
Oh, it's
this dark
barium.
area
Oh.
in the rectum?
That's air, gas.
Okay.
It's gas.
Is it airy poop? Is that what you said?
It's a fluffy poop.
Shows up black.
That's good. It's just air.
Poop is solid.
I know, but it still shows up black.
It's a
I mean,
poly-
Air is black.
okay.
So that's
You didn't like my answer? Poop is solid.
Yes.
So there's going to have some density to it.
Yes.
If it's black, it's air.
Okay.
so it's
Okay.
air.
I don't know. Hemorrhoid?
It's air.
It's that. It's this. The retention balloon. It's the retention balloon on the enema tip. Okay, holding that, holding the enema in place is what it is. So that's the balloon. Yeah. There's a hole in my bag. Yeah, it's broken.
Got too much use.
What's the maximum diameter that balloon can actually expand?
Well, let's see here.
Or it depends on the model of the.
No, I think it's about 10 cc's of air. 10 cc's of air. Yeah,
Have no clue.
yeah, I believe it's about 10 cc's.
It's like a syringe. Okay, that's not.
That's worn out. Okay.
So if you wanna torture someone, it's not, I'm gonna be too bad.
All right. Here is in this position. And this is an LAO position, single contrast. Everything looks kind of convoluted, right? So keep in mind again, so that when you are rotating the patient, things kind of gravity kind of puts it aside, but also because of the position of the colon, it makes everything look compact. So give me a second here to just kind of pull the app together, so it gives you a better visual of what we're looking at here. So you guys talk, just talk while I'm pulling this up.
So very minimalist.
Yeah, there you go.
Balloon. Yeah.
That thing is called an inflator or indeflator. I think I have some extra ones in there. I just gotta find it. Why is this? Oh no. This is my app. How come it's not letting me open it?
Maybe it's meant just for you.
Well, it's telling me I needed to put my code. I don't have my code with me. I installed this last year and it was working fine.
So is that code valid for a particular amount of time?
Oh yeah, I purchased it.
So maybe it expired?
Well, that sucks. See? There it is.
Nice.
How did you?
Hide others?
Hide all of them, okay. It has to be
Because I think the feeling it's only bones, right? Right? You're right.
Okay, so this position here, let's go back to see what it looks like. It says it's an LAO. So an LAO would look something like, an LAO would be, an LAO, the opposite of an LAO is an RPO, right?
Mhm.
Okay, so let's do an RPO. Okay, now does it look very similar?
Да.
Kind of, okay. So this is what happens in this position. So this is your ascending right here, okay? And if you're looking at your manual over there, your slide, it says that C is the hepatic flexure. Well, you can't see the hepatic flexure because the transverse and the ascending are covering each other. It's looped up on one another. So it looks like just one big mess. So they overlap. So in this position, you lose the hepatic flexure. There's some overlap to it. So here is the ascending and then hepatic. And then in this picture here, it says this is the transverse. Well, this is the transverse when you open it up.
Mhm.
See, that's the transverse. Transverse. And that little bend there, this bend right here is the splenic. And then it comes down to the descending. Okay, then there's going to be some overlap of the sigmoid rectal area, which is this area right here. So when we have this app, does it make a little bit more sense in looking at that image?
Totally, yeah.
Okay. Okay.
So on the radiograph, all inside this big loop, right? Is it like a small bowel that also has a contrast?
No, this is all large bowel.
That's all large?
Yeah, so his rectal sigmoid area comes up like this.
Oh,
It's
okay.
a huge giant S, so it goes, here, let me just blow this up. So his sigmoid, so this is all descending, and then comes up like this.
Sigmoid, oh.
Okay?
Mhm.
Yeah, see, that app is so good. It helps me better understand anatomy. It's just so much clearer. Okay, then we have a cross-sectional cut. You guys can look at this later if you want, but you have your liver, gallbladder, duodenum, stomach, let's see, jejunum, kidneys, descending colon. Anybody interested in taking cross-sectional anatomy?
Yeah.
You guys should do that. Especially, when is it offered? Do you guys have any idea? I don't know.
In the fall.
So next semester or right now?
Next semester.
Next semester, okay. I would say, take it because it will help you in that when you have the opportunity to rotate in the other departments like CT and MRI, and they're showing you what they do, and then you're pointing out the different anatomy, you're gonna be like, whoa, they'll be blown away, right? And so now, at the end of your program, let's say, hey, this guy knows, or this girl knows a little bit, about what we're doing here. They'd be a good fit for our department. And that's what happens with our new graduates. They end up working in CT or an MRI or specials or cath lab right when they graduate. Or maybe a couple months down the line. So it's good to get that head start. Okay, so last week we covered this part. So summary of lower digestive system functions. So a majority of the digestion, absorption, and reabsorption occurs here in the small intestine. So digestion of the different foods and fluids, nutrients are absorbed, and then reabsorption of water and also salts occurs here in the small bowel. Now, 1, 2, and 3. Large intestine, the major function of the large intestine is to eliminate the waste. That's it. Because only about 5% of the nutrients or water is absorbed. So only 5% occurs at the large bowel. Everything else is try to get rid of any of the waste material. Okay. Also, what's happening here in the large bowel is there are absorptions of also vitamin B and K, and also some amino acids, but this is produced by the bacteria in your large intestine. So the bacteria produces this in the process of breaking down or eliminating any of the material, and it is absorbed. But also in the process of producing vitamin B, Ks, and other amino acids by the bacteria, in that process it's also producing gas. Okay? And so that's where you have flatus. And flatus helps in the breakdown of any remaining proteins and amino acids. So they produce it, they break it down. Produce it, gas is formed, and also the gas also helps break those elements down. Okay? And then feces is a product of water, some solid food materials, secretions, and also bacteria. So any questions about this slide? All right, so movements of the products in the digestive tract of the lower GI is moved with peristalsis. Remember the little pouches, haustral churning, where it propels the products from one pouch to the next. Mass peristalsis, and then finally defecation. All right, so some contraindications for barium. It's metal. It's non-absorbable, right? So we don't want this contrast leaking out of a closed system. We don't want it leaking out of the bowels. So if there's possible perforation of the bowel due to some injury or illness or surgery, can cause perforation. Okay? We don't want that because we don't want the contrast leaking into the peritoneum. Then we have possible large bowel obstruction. Well, if the contrast goes in there, how is it going to get out? Okay, it gets in there, it hardens, now we've got some problems. And appendicitis. Appendicitis is a contraindication for barium because barium gets in there, it can't get out. Can cause severe inflammation. We've already got inflammation, but can cause worse inflammation. Now the whole thing about appendages. Nobody knows what it's for, but when you have problems with it, it can actually kill you, right? You've heard about complications with appendicitis. So if you get contrast in there, it's non-absorbable. It can exacerbate that and cause a lot of clinical problems. What they're finding out now, I've been reading some studies, is that it may have something to do with your immune system. Did you, you're shaking your head up and down. Have you read some of that? Oh, I said that before? Okay. It's my age catching up with me. Yeah. All right. Purpose of doing a barium enema includes ulcerative colitis, diverticulosis, diverticulitis, neoplasms, volvulus, intussusceptions, and also polyps. So here we have an advanced stage carcinoma of the colon. When they discuss neoplasms and it has that look, it's called an apple core or a napkin ring, indicative of cancer. And it can either be a partial obstruction or a total obstruction that can be caused by that cancer. Here are some images of ulcerative colitis. Now, if the patient is suspected with ulcerative colitis, again, ulcerative means that there is a breakdown in the lining. So if there's a breakdown in the lining, that would be a good indication or contraindication not to use barium, and they should be using gastrografin. Okay? Because the barium is going to seep into the ulcer and again cause complications. Okay. Diverticulosis of the sigmoid colon. So what's the difference between a diverticulum and a polyp?
It's outpouching.
Yeah, direction of the pouching. So outpouching is diverticula, and then polyps are inpouching. And so we have a radiograph here in the sigmoid area where you have, what is this? It's out, right? It's on the outside. So what do you call that?
Divertical.
Diverticula. Okay, or diverticulum. So this is what I put up here. This is on your new set of slides. So this is what I uploaded. So the difference between diverticulum, diverticula, diverticulosis, and diverticulitis. They all sound the same to me.
Sucks.
But apparently there are some differences. So diverticulum is singular. Diverticulum is singular outpouching, and then if you have many of them, it's diverticula. Okay. Now, diverticulosis. So diverticula is the outpouching, but the condition of having these is called diverticulosis. The outpouching is called diverticula. The condition is called diverticulosis. And then diverticulitis is inflammation or infection of the diverticula. Oh, it's all over the place. It looks bejeweled, right? Bedazzled. Okay. Everybody got this?
Is that both diverticula and polyps? What is being shown on?
I don't know. I mean, I see a lot of the diverticula. You can't, it's hard to see the polyps because it's inside.
Mhm.
And if you got contrast in there, it may, you may block it. So, but there are ways to study polyps, and we'll talk about that in the positioning. Yeah. It's harder to see the in-pouching, especially if it's filled with barium. So to answer your question, I can't tell. It's not the correct it's not in the correct position to identify polyps.
So is this a picture of diverticulitis or osis?
I don't know. It could be both. Yeah, it could be both. All right, then here's polyps. They're in-pouching. And so this is why double contrast study is really good. So if there is no, without the barium, you have just enough barium just to coat the lining, just enough to coat it, you can see the polyps. But if this was filled up with barium, now it's hiding. Okay, what part of the colon is it pointing to? Ascending. How did you come up with that conclusion?
The loop, how it drops, the
You can
transverse.
see the appendix.
Oh yeah, okay, the appendix.
And then it's like-
In the appendix, yes. Yeah, okay, so this is ascending. All right, so here's your neoplasm. Again, we have the napkin ring or the apple core. You can have partial or complete obstruction. Cecal volvulus. I put a different picture up there than the ones that you had. The one that was on your slide was a little bit too dark, so I substituted with another picture. But here is a cecal volvulus, where it's a twisting or torquing of the bowel. And so remember, your large bowel produces a whole bunch of flatus or gas, and the gas has nowhere to go. I mean, it can go one way, okay, but because of that blockage right there, it's causing that extra distension of the entire colon. Okay, here's another volvulus, right? Actually, two of them. And so the doctor would have to determine, is it a volvulus or is it actually a what do you call it, a neoplasm? So the doctor will have to determine that. Now, next question. Should they have, if they was suspected volvulus, should they have used barium?
No.
They should have used iodine, okay. So I'm hoping this is iodine and not barium. Intussusception is the telescoping. It generally happens in the ileocecal area because you're going from a small diameter to a larger diameter. So the small intestine usually telescopes up into the large intestine or the cecal area. So this is most common in that junction. All right, so barium enema preparation. What are they? All right, so let's look over here on the far right. It's important to eliminate as much fecal material from the colon and rectum as possible prior to the examination. A clear liquid diet and cleansing enemas are often used to empty the colon. Occasionally, further medications that evacuate the bowel also may be necessary. So, they can have a light meal, the light meal being some kind of liquid diet, so broth, juice, whatever. Not pulpy juice, just regular juice without any pulp or any type of contents in there, any type of fiber, fiberless. Okay, so they can have a light diet, but NPO after midnight. They may provide them with bowel cleansing cathartics, laxatives to help empty them out. And then when they arrive to your department, make sure that they haven't had anything to eat. So again, you can ask them, have you had anything to eat? Have you had anything to drink? And then also ask them, have you had any coffee or juice? Many don't consider coffee and juice as breakfast or fluid. Don't know why. But you should ask that. Okay, so have you had anything to eat, anything to drink? How about coffee and orange juice? Again, it's good to know whether they've chewed any gum or haven't smoked. But you'll never hear your technologist ask their patient that. Okay, it's one of those things that they omit. Okay, so if you hear them omit that, don't be surprised. Okay, and then they also may have another enema, some type of cleansing enema prior to the procedure. So cathartics then are substances that produce frequent soft or liquid bowel movement. There are two types. They are irritants and also saline. What I've done is I've listed the most common type of laxatives on the market. These are all the, not the generic names, these are all the brand names. Metamucil, Citracil, Fibricon, etc., etc. Now the contraindication to cathartics, first of all, you don't want to do it if they have gross bleeding, okay? Because it can exacerbate, because what these cathartics do, it promotes contractions. It promotes peristaltic activity. So if you have bleeding, it can exacerbate any type of bleeding in the internal bowels. Severe diarrhea, obstruction is another one, and also inflammatory lesions. So just like in the other exams, whenever you do a fluoro study, you also need to take a scalp film. The purpose of the scalp film is to what?